the first of our monthly sepsis lecture series that is being put on by the BC Sepsis Network. For those of you who don't know, the BC Sepsis Network is a group of clinicians and managers, administrators who are all interested in sepsis quality improvement and education. And not only do we promote these online lectures, but we also have an online platform called Q Exchange that we'll discuss at the end of Steve's lecture, where we have active discussions around sepsis improvement. I will discuss how you can get involved in that in our network after the lecture. So in the upcoming months, we actually have a lot of exciting world-renowned lecturers presenting. Just a few, we have a member of one of Scotland's EHS system who's going to be talking about implementing pre-hospital lactate measurements for sepsis identification. We have Dr. Anand Kumar talking about the importance of antibiotics, Dr. Laura Lynn McIntyre talking about fluid choices and sepsis resuscitation and more. So make sure to stay tuned and listen for our lectures that come out, usually one lecture in the later half of each month. So for today, we're very lucky to have Dr. Steve Reynolds presenting with us. Steve and I actually did our fellowships in critical care together here at UBC, and he is a close friend. He's an amazing clinician, so we really are lucky to have him here talking to us today. He's dual trained in both critical care and infectious disease, and currently he practices at the Royal Columbian Hospital, where not only is he department head of their ICU, but he is also their research director as well. Steve has many publications and book chapters, too many to really list, under his belt, and was recently awarded the Fraser Health Scholar Grant to further his work looking specifically at procalcitonin. And he really is truly one of the leaders of this field in Canada and North America. So thanks so much for being here, Steve, and we're really looking forward to seeing what you have to teach us about procalcitonin.
Wow, thanks, Dave. That's I feel honored to be amongst the group that's lecturing. That's quite a impressive group of people lecturing, and as Dave knows, I'm usually more full of hot air than anything else. So hopefully I'll try not to bore you too much this morning. One of the things that I'll try to do very much so is I'm happy to stop the lecture and to chat about anything in particular. I've tried to aim the length of the lecture to give time for discussions around various issues. So if there's something that you want to talk about, or if you have an issue or a question about the slides, you know, feel free to put the hand up, and perhaps we can spend a bit more time on those issues, or we can return to them at the end. I'm fine either way about doing that. So I guess I now have, do I have control of the slides now? I think so.
Yes,
yeah, I
do.
Okay. So I have no disclosures relevant to this presentation. Specifically, I don't get any money from any of the people making procalcitonin or anything like that. This is the Royal Columbian Hospital. It's a place where I work. Unfortunately, I feel like this is where I work. This is the Columbian Hospital. I think it's 1914. As I think we all have a challenge right now in the sense of resources and money and patients in the hallways and things like that, and it makes us anything that we can do to make our dollar stretch a little bit more and do it in a safe and reasonable fashion, I think is important to do. My hospital is well known for managing patients in Tim Hortons when our emergency department got a little bit full, and I love this quote from the Globe and Mail: "If it hurts, take 2 donuts." It makes me feel like a real healer. This is how we renovate at the Royal Columbian Hospital. We have people, unfortunately, patients drive their car through or their trucks through the front doors by mistake. So this is this is a real picture. So what will I talk about? It's actually quite fun. Normally I can hear people snickering, at least in the background, when I give those presentations, but on WebEx you guys could all be sleeping or rolling your eyes. So hopefully I had some relevance there. But in terms of procalcitonin, so I'll talk in terms of our overview of the talk. I'll give you a sense of what procalcitonin is. The second issue is there evidence outside of the ICU, because I'm an ICU critter. I do most of my time in the ICU managing sepsis. We get involved quite early in the emergency department of my institution, but still a lot of the information that we'll focus on in terms of sepsis is this the later on management and what happens with sepsis over time, and how can procalcitonin play a role. Specifically, we'll ask the questions: can it be used as a surveillance or an early warning system in the ICU infection? Does it have correlations with mortality and appropriateness of antibiotics? We'll also talk about, can we use it safely to stop antibiotics in the ICU, and then I'll give you some of my opinions about how it could fit into management of critically ill patients and septic patients on an ongoing basis, and where it's reasonable and may be a safe cost-saving measures, what questions we still have about it, and where we're at, and some warnings about how to be careful about introducing procalcitonin and some of the concerns about it. So first thing, procalcitonin. So procalcitonin is a pro-hormone for calcitonin. It's produced by the majority of the inflammatory cells in the body. It's expressed along with other cytokines in response to infections by bacteria and some fungi. It's relatively specific for bacteria in the sense of it doesn't go up with viral infections, and it can be elevated in things like surgery and major trauma, but initially at least it was sold and evaluated as a lab test that was more specific for infections. Very much so, it's much more specific than things like CRP. We know that in observational studies, steroids, the presence of steroids, doesn't affect its rise or absolute level. It shows good discrimination, as I said, between viral and bacterial infections. Its elevation, so the magnitude of its elevation, correlates with bacterial loads and the severity of infection. And in terms of how it increases within about 6 to 12 hours of stimulation. And when the infections are controlled, the lab value halves daily, so it reduces relatively quickly when infections are controlled. So in terms of the evidence thus far, we'll go through in detail the stuff on sepsis, but it really has been looked at in observational studies. So on the left side of this graph, a fair number of clinical circumstances. And in the interventional studies, really what we'll focus on will be obviously this severe sepsis and septic shock, but they have looked at, and as we'll talk about, there's a fair amount of data in the pneumonia and outpatient COPD population, upper respiratory tract population. Other uses that just briefly people have talked about it, looking at it using as a differentiation between bacterial infection and autoimmune disease flares, which is, I think, an interesting use. Although there hasn't been a lot studied or published on it as an integrated member of or integrated part of antimicrobial stewardship programs, there is some increasing or emerging evidence that it may be a reasonable option. This is from, I think this one was from Taiwan. This is a bit of a busy slide, but what I wanted to show you from this and to go through just briefly was a few things. So first, these are the randomized controlled trials looking at decreasing antibiotic usage with PCT. And what we see in this is there's a mix, and as I said, we'll go through the sepsis ones in more detail. But there's a lot of ones that look in the emergency department. So there's a fair amount of evidence that really emerged, and PCT really got its foothold in the emergency department, looking at outpatient antibiotic usage for pneumonias and COPD exacerbations. So these diagnoses, you see cap, down here. And in here, just I want to point out the emergency department usage, because this is, again, not something we're going to focus on, but there is a fair body of literature supporting PCT use in terms of controlling and reducing antibiotic use. And the research questions generally were reduction of antibiotic use in this context, and as a general rule, they did find a significant reduction in antibiotic exposure with PCT use in an outpatient population. A meta-analysis recently done really focused on this, and, there you go. So it showed a reduction of 1 to 7 days in terms of duration of antibiotic use, and the prescription rate again went down by 2 to 7%. So when you think about this on an individual basis, if you reduce antibiotic use from 1 to 7 days, well, let's say you're reducing it by about 3 days, in any individual user, that's really not going to be a major cost or you think an overwhelming impact. But the flip side, on a population basis, if you're reducing 3 days of antibiotics in your population, that could be a massive use or a massive reduction. and a reduction both in antibiotic exposure with consequences of antimicrobial resistance as well as costs to the system. That would be huge. The other thing to point out is that there were, in any of these studies in the meta-analysis in general, there were no worse outcomes, which was obviously encouraging from that perspective. So this slide is meant to show you really the general use of procalcitonin in the research questions in general, and the suggestion of how they're meant to be used going forward, although this is based on a fair amount of expert opinion. Procalcitonin essentially is used as a cutoff to point out things like between the various levels of procalcitonin and what to do about it. So when you look at here, you can see things. When you look across, you can see when the procalcitonin is very low, you should look at not withholding antibiotics. When it gets up a little bit, again, you should consider withholding antibiotics. After you hit a certain point, and in the low acuity patients, this is 0.25, then you should consider starting antibiotics. In the moderately to high risk groups, it's a similar type of cutoff, but even in the relatively low risk groups, they say consider antibiotics treatment, but you can also consider overruling that point when you cross it with clinical suspicion of infection. And we'll talk about why this is a really important point in procalcitonin, because my bias, and I'll return to this as a theme again and again, that any single lab value is not something we should always hang our hat on as a clinician, but we should put it into context. Increasingly, I'm starting to see procalcitonin almost like a CVP measurement of infection, where a longitudinal study of PCT can be useful. It can be useful for specific questions, but a single lab value of PCT can be misleading, and I'll tell you why over the subsequent few slides. So I'm going to talk now about the sepsis and ICU-specific studies, because this is sort of where I live, but this is also the more severe infection type of circumstances. So the first thing is we'll talk about PCT as a prognostic marker. So can it be used for that, and can it be used to look at antibiotic adequacy? There's been a fair amount of studies from the Greek group looking at this, and what they've done in particular, I've chosen this study in particular because it exemplifies two different things about procalcitonin. The first one is that when procalcitonin is low, and you can see here low is below 0.25 nanograms per milliliter, or it falls quickly, then the mortality is better. So that's the solid line are the patients are group 1 in the sense of the people who, our group 2 there, that's group 1 here. So their survival is better. So if your PCT is low or your PCT level drops quickly following admission, you have a better survival. We also know that the groups of people who have their PCT when it's high, not only do they have a higher mortality, but they're much more likely to have inappropriate antibiotics with an odds ratio about 2.5. So again, just to reiterate that, if you get admitted and your PCT is low with an infection, you're more likely to survive. If it's high, obviously your mortality is higher. If your PCT is high and stays high, you're much more likely to have inappropriate antibiotics or have been given inappropriate antibiotics. So the next thing is, can we use PCT as a means to look for infection or emergence of infection and the development of sepsis? So can we use it as a surveillance system for patients on the ward or in the ICU, where we think that sepsis, if we intervene early, and that's one of our main tenets of managing sepsis, can we make a big difference if we jump in and have a lab value that tells us something is going wrong early? So there was quite a large Scandinavian study, the Jensen study, with 1,200 patients, where they what they did is they looked at procalcitonin values daily in an ICU population in patients that were not infected at the time. And they were looking for the development of incident infections rather than managing patients who had already came in with an infection. They had their protocol was essentially if your PCT level was, it's relatively high, so greater than 1 nanogram per milliliter, or it didn't decrease and stayed a little bit under 1, but stayed stable over time and didn't decrease, then they had what they called a PCT alert. So a message came out to the clinician, a big yellow sheet that said, oh my gosh, your patient must be infected, you better investigate. So oftentimes they would, and there were suggestions for the investigation, including blood cultures and either introducing new antibiotics or altering the patient altering the antibiotics the patient was on, and suggested CT scans and X-rays, et cetera, et cetera. They found that this strategy was actually bad. It increased the ICU days, it increased antibiotics, it increased ventilation days. It really made things worse. It freaked clinicians out, and as you can see here with the table at the bottom, it increased the ICU days with mechanical ventilation. That was just as an example, significantly. So procalcitonin in and of itself as a surveillance mechanism is for patients in general is a bad idea. And that it seems funny because if we have a lab value that we think is relatively specific for infection, why is it driving something like this? Why is it? It should be a good surveillance mechanism. So there was a recent study from Belgium as well that looked at using PCT to diagnose specifically infection in the patients who they know are infected. So if somebody came in or you were suspicious that they had developed an infection and you used a single PCT value, they correlated this with retrospective analysis or evaluation by an infectious disease doctor to look to see if they, in fact, were infected. So the gold standard was retrospective evaluation by a infectious disease doc. So when the PCT was high, and high was, again, a reasonable high number, greater than 1 microgram per liter or nanogram per milliliter, they found on retrospect that in this case PCT was high, but there was no infection in almost 34% of cases. So a single value of PCT was not particularly useful when it was high. And then when it was low, so it would suggest to you that you should stop antibiotics or not use antibiotics on a single test. In 15% of cases, an infection was present, and in a few cases, there was severe sepsis associated with that. So that's a real concern for this lab test, because you say, whoa, so you're telling me that this diagnoses infection or it's specific for infection, yet I can't use it diagnostically and I can't use it for surveillance. So what's going on with that? And you can imagine this is the picture of the receiver-operator curve, and it's pretty dismal in terms of PCT as a receiver-operator curve. The area under the curve is 0.69, which is, you might as well just go home and not use your test rather than add that to your clinical bit. So I think to answer this question, there's a few different things that go into that, why PCT is not acting like we want it to in that context. The first thing is that there are some other stuff and some other that affect PCT that we could certainly see in an ICU or a critically ill population that may overlap with sepsis. In a study that myself and my collaborators published in 2012, we found that we looked at a cohort of patients and we had an independent adjudicator of sepsis. So 2 of us had gone through and decided whether somebody was actually infected or not. And we found that the presence of shock itself, so hypotension and hypotension, the absence of infection, would yield an elevated procalcitonin level, and to the extent that it's actually over 1. So even though we think that procalcitonin is relatively specific for infection, there certainly are issues that cross over with this that are present and confound this that are present in relatively high levels in the ICU, and that's the presence of shock. We found that, from a research perspective, it was good because medical and surgical cohorts are relatively similar, and we found slightly different patterns with prevalent and incident infections. So there are other things that affect PCT, number one. The other way to explain some of this previous data, particularly this Belgian group, is that remember how I told you at the beginning that PCT takes about 6 to 12 hours to elevate. So it depends on the acuity and how early you present in terms of your infection. So again, PCT as a single measurement may be misleading to base too much information on. So that's, just to briefly talk about, we talked about PCT as a diagnostic mechanism in septic patients. We've briefly talked about PCT as a surveillance mechanism for the emergence of infection. And both of those have said, well, no, I don't think there's a whole lot of good evidence to do this. And as a matter of fact, we should be pretty leery about doing that. The next thing is, can I use it PCT to safely stop antibiotics in critically ill patients and septic patients? Can we use it to on an ongoing basis to reduce our antibiotic use? So I'll tell you about the meta-analysis that we did, and then we'll go on to talk about the big study that really drove the effect. There's 5 studies in the ICU that looked at PCT specifically as a means to stop antibiotics. When you look at a meta-analysis and you put them all together, they showed a pretty solid signal that they reduced antibiotics by 2.14 days. That was our number, with no significant differences in clinical outcomes. But it's important just to point out that what we're looking at here is that with all statistics, right? There's, Mark Twain said there's lies, damn lies, and then there's statistics. But in this is specifically mortality. There could have up to 7% difference in mortality that we wouldn't have been able to detect with the power of our study, or even the power of the collapsed studies together in the meta-analysis. And one of the major criticisms of procalcitonin as a means to reduce antibiotic usage is this issue that, is it really worthwhile to stop 2 days of antibiotics when we could be killing up to 6% of our patients? And again, I'll return to this at the end, but just to comment somewhat on it now, this is why we can't use any single lab value in isolation, because I think it's dangerous, and we should never really turn off our brains as clinicians. We have to always put it into context. This is our some of the graphs from our meta-analysis. The first one here, the top one, is the duration of antibiotic days that are reduced and it favors the experimental, which is the procalcitonin algorithm, and it's that minus 2.14 days. That's the days free of antibiotics. And this down here, if you look at it, is our hospital mortality, and you can see that again it crosses 1, doesn't really show any specific effect. So again, there's no difference in terms of mortality between the 2 different groups. And then one of the, of course, you have to talk about things like money in this context. Obviously, we want to make sure, the key is to make sure everybody is safe and to have the best patient outcomes. But one of the most real effects you'll start to see if you actually reduce antibiotic usage is the cost number. And that's what an administrator is going to want to know is how much can I save by doing this stuff. So all cost-based analyses are a little bit, I don't want to say sketchy, but they're based on a fair amount of assumptions. So we looked at 3 different treatment strategies of an average cost of antibiotics, a cheap cost of antibiotics, and an expensive cost of antibiotics. And of course, this is going to vary per place, per institution, the cost of the various antibiotics. Our average antibiotic cost was based on a uridopenicillin like Piptazo and a course of that. Our cheap antibiotics were based on a 3rd-generation cephalosporin, so relatively inexpensive from that perspective. And our expensive one was based on a carbapenem, and usually it was a vancomycin or linezolid dose. So a pretty expensive course, not unheard of in an ICU, but again, a pretty expensive thing. And if you look, we made sure we put out our procalcitonin guided therapy costs. This includes the cost of procalcitonin, which varies again per institution, but can be, I think it's $20 per $20 a pop, but it might be a bit more than that depending on, no, actually, here you go. We assumed $50 per test. And then the standard therapy cost was over here. So we argue that on an average antibiotic use in an ICU patient, you'd save about $500. If you're only using cheap antibiotics in terms of for the patient, then really it would be more expensive to use serial PCT to follow up and to reduce antibiotics. And if you're using the expensive, the Cadillac stuff, you'd save a little bit over $1,100. So again, these are not impressive numbers on an individual basis. You think about what a day in the ICU costs, and this is really not a whole lot. But when you put it into context of your population and a reasonable usage of the test, you can actually talk about saving a fair amount of cash and reducing your budget significantly. So I think it's worthwhile when talking about the procalcitonin within the ICU context to talk about the biggest study to date that was done and really drove a fair amount of the effect of the meta-analysis. And this was a very well done study out of France, the PRO-RADA trial, and it was published in the Lancet in 2010. It was a large trial of 630 patients. It was a multi-center trial, and they showed a 2.7-day reduction in antibiotic use and no increase in mortality. So great, really good, and some fabulous well-known researchers. Jean Chastra's on there. Michael Wolf was published a bunch in this area too. So really quite impressive in terms of a result. This is the guideline that they used. The first you'll see at the top, they had a guideline for starting antibiotics. It's interesting, they didn't really have a lot of effect in terms of procalcitonin starting antibiotics. These were just suggestions that would go out to the clinician. So the PCT value would be taken, and a suggestion would be given to the physician in terms of what to do. But what was the most relevant was the guidelines for continuing or stopping antibiotics, and this is where this is what really drove their effect. Again, the clinician would be getting the procalcitonin value would be measured, and they would get the same day they would have a suggestion saying either if your procalcitonin is low, you should stop antibiotics. If it's a little bit higher, you should probably still stop antibiotics. If it's high, you should continue. And if it's really, really high, then you should change your antibiotics. And so that was in the bottom there. You can see the 28-day mortality, there's no effect. On the 60-day mortality, there's no effect. And the number of days of antibiotic is reduced by 2.7 days, which makes everybody feel good. Now, some of the criticisms of the study, the first one is that this is the Kaplan-Meier survival curve, and if you see the red group is the procalcitonin group. And their survival, as you get out to 60 days in the procalcitonin group, is less than the control group. But there's a few odd factors about this. One is at 60 days it's not clinically significant. But you can definitely see that the curves have started to split. They split at 30 days, which is really odd because we're talking this is almost 2 to 3 weeks after they've stopped antibiotics that you're having a difference in mortality, which is, again, like I said, a bit of an odd difference. So that hasn't been really looked at in the other studies to date in the ICU. 60 days is a nice long time frame to follow patients out to, but many of the previous studies did not look to 60 days. So I can't really explain that. And then the other thing that was a bit odd is when you dig through the paper, you find that 53% in the procalcitonin group, so the experimental group, didn't actually follow the algorithm that they were supposed to. So they had, as you can remember, that previous slide was a suggestion. So you can imagine you're an ICU clinician at the bedside rounding, and you have this big yellow sheet saying your procalcitonin level suggests that you stop antibiotics. And 53% of the people didn't follow that algorithm. Now, talking with some of the people who had participated in the trial, it appears that a fair number of those were because the patient actually left the ICU and was in some ways lost to follow-up or lost to at least the intensivist managing them for their sepsis. But we're not sure how many of those patients were that way. It's not clear from the paper or any other associated data of this breakdown of people that or the treatment violations. And from a clinician looking at this perspective, it makes me a little nervous because what's in that 53% of patients, what's going on clinically that inform these clinicians to not follow a lab test? And even though you see this 2.7 days of reduction of antibiotics, I don't know what they're doing at that center, and I don't know if my center would replicate it the same way. So it really makes me concerned about the generalizability of this study, although it's tantalizing in the sense that you almost drop your antibiotic use by 3 days, which I think is a reasonable thing to consider and aim for. This is their graph, just to point out. The red is the procalcitonin group. These are the percent of patients receiving antibiotics, and you can see relatively quickly there's a division between the control group and the procalcitonin group, and this area in between the two curves is really the area of antibiotics that you save. And just to reiterate, if you can imagine 3 days of antibiotics, and you have in my unit you have 800 people. We had 800 admissions, or a little bit over 800 admissions last year in the ICU. And I'd say, just eyeballing it, about 3/4 of them, or maybe half of them, have antibiotics. So if I can stop 3 days of antibiotics in 400 of my admissions per year, that makes me feel pretty good in terms of the impact and the costs. So I'm getting onto the summary slide, and as I said, I've tried to make sure I've left some time to talk. But first thing is, can I use PCT to diagnose sepsis? And I would say the answer is no. And the other answer would be is, why the heck do you want to? We all know that when patients come in and they're sick and they're in shock, it sometimes, in the textbooks and in the articles, it all seems very easy to diagnose sepsis. They have distributive shock and their blood pressure's low and all the other things. In the practicality of day-to-day work, it actually isn't, I find, easy to diagnose. There can be lots of different things going on. You're trying to get lines in and intubate and do all these other things. And I would say that anybody that even sniffs like sepsis needs antibiotics and needs aggressive antibiotics. That's funny to hear an ID guy say that, in the sense of we're always screaming about rational antibiotic use. And I think you can, the stuff that you guys are working on, and Dave's, I know, done a bunch of work on algorithms to make sure you have the right antibiotics for the patients, I think is really important. But what I'd also say is, I have another lecture series or a lecture set that slide set that I like to use, is that choosing antibiotics initially can be a little bit difficult, but it isn't too bad. Hit broad, hit hard if they're sick. Don't miss. Don't be too smart. Don't be too fancy. Use the antibiotics that are appropriate for their site of infection, but make sure you don't miss. It's the day 3 to day 4 that you start to have that the dust settles. The pneumonia has blossomed on the chest X-ray. They have purulent sputum coming out. And now you can say, okay, well, they have community-acquired pneumonia. Let's rationalize our antibiotics, whether we have cultures back or not, and use things that are appropriate for, a severe community-acquired pneumonia rather than for undifferentiated sepsis. And I find that takes a fair amount of discipline, is quite difficult. But using PCT to diagnose sepsis at the beginning, I don't think it's particularly useful. Can I use it as a surveillance or an early warning system in the ICU for infection? So no, you can't, right? I think that there's enough variation in PCT on individual measurements that it drives unnecessary evaluation of patients, and it doesn't add anything to our clinical suspicion. As a matter of fact, it detracts from our regular clinical work. Does it reflect adequacy of antibiotics and correlate with mortality? Sure. Yes, it does. But, we have lots of good things. Well, we don't have lots, but we have measures that correlate with mortality, and I don't think we really need anything that helps us from that perspective. And in terms of reflecting adequacy of antibiotics, that's a tough one as well, because I would imagine that if your patient is not getting better with sepsis over 2 to 3 days, you're thinking about changing the antibiotics and looking aggressively for source control. So I'm not sure how much it would add from that perspective. But I think as we look forward, can it be used safely to stop antibiotics in ICU and septic patients? And my answer would be, I think so. There seems to be good evidence to suggest the fact, and it seems to be a reasonable thing to look at as an aid to stopping antibiotics when taken in conjunction with our clinical decision making in that context. So rather as a binding thing, as a comment that you suggest, we still have to figure out what that Boadna's 53% of violations were in the sense of generalizability. But I think it's reasonable to consider this. So this is, now I got to give you, now we go on to entirely opinion about how PCT should fit into an ICU and management generally of a septic patient over time. So the first thing is I would say avoid early aggressive adoption. As a lab test that's $50, we all have, hopefully we've all learned from the history of things like BNP when it came out that it's tempting to use it as a clinician just to, number one, to get familiar with it, but also to put it, to get it into context and everything else. As an ICU doc, I don't really care what the CRP of a patient is if they're critically ill. And the same type of thing is, I think we should avoid early aggressive adoption of PCT. I know that there are some places that have, and they have used up their lab budget very quickly just on PCT values. The other thing I think is to put it in context of a rational antimicrobial stewardship program. So the first thing is if you don't have a good antimicrobial stewardship program, to establish that. So rather than putting money into PCT, get people who can really get the low-hanging fruit of antimicrobial stewardship. Do things that we know which are there already. The Jean Shastra study of 8 days versus 15 days for VAP. That should be a religion in the ICUs in the sense of this is the data that we have. The other thing is that once PCT values, I think, can be put into context, and if they're used correctly, they can save antibiotic use, thereby saving money. But I also think in the grand scheme of things, they can impact on morbidity and antimicrobial resistance in any particular unit by reducing inappropriate antibiotic use. The reason why, for me in general, that I got interested in Procalcitonin was because my pharmacist, Doug Maliak, would always tease me that I was the natural antibiotic cycler in the unit, because I'd come in and I'd stop all the carbapenems and I'd stop antibiotics early. And I started to think, well, I don't think I don't think what I'm doing is anything particularly different, but antibiotics are this safety mechanism, and we always feel much safer if someone's on bug juice. But I think we all know that we cause problems in the future with it. So how can we give a clinician a tool to help stop antibiotics in a reasonable, rational way? And I think PCT is the first part of a solution. Now I'm going to go into a shameless pitch for my study that I'm working on now. It's a pilot study using PCT and a clinical program or a clinical, a very, very simple clinical algorithm to stop antibiotics. So essentially when the PCT level is low and white count is normal, temperature is normal, and patients don't have any pressors or don't have any further pressor requirements, the patients in the experimental arm will have their antibiotics stopped automatically and a placebo sent up. You can imagine that right now I'm having a challenge recruiting because there's such an ingrained sense in North America that you have to finish your antibiotic course, both from a clinician perspective, although the clinicians are bought on, they see the clinical equipoise, but families look at me like I'm from Mars when I try to tell them that, we may not need antibiotics for the 14 days and that, there is good evidence in things like ventilator-acquired pneumonia that 8 days of antibiotics are sufficient, and it may even be less than that. So, yeah, if anybody has any comments or questions about this study or wants to participate, let me know. And that's really what I wanted to say. I wanted to leave some time for discussion. That's my email there. And thanks for listening to me.
Great, thanks, Steve. So we've got some time for questions. I'm going to try unmuting everybody's line so that you can just pipe up and ask a question. And the other alternative is to type a question into the chat box, or you can click on your virtual hand, which you'll see that little icon just below the list of participants. If you click on your virtual hand, I'll call on you and you can ask your question.
Maybe while people are thinking there, I'll start off with the first. It's Steve Sweet. I know you said in the beginning there when you were talking about procalcitonin that you looked, I think in that sample, that shock non-specifically would elevate your procalcitonin regardless of the cause of the shock. Is that correct?
That's correct, yeah.
And so have they looked, I didn't know if you alluded to this specifically, so diseases that are inflammatory conditions but not infectious, such as severe pancreatitis or severe hepatitis that weren't infectious, even in or out of shock. Did you know if those groups would have elevated procalcitonin, or if you were a non-shock severe pancreatitis, would it not be elevated?
So we don't know. That's the first answer. The second thing I would say, it's tough to adjudicate those, whether there's the absence of infection as well, right? Whether they have a pseudocyst and things like that. And same thing with severe hepatic dysfunction. Oftentimes there's, as you know, right, they're tipped over by an infection, and they have distributive shock, and we're not quite sure what's actually doing it. And then the last thing is the numbers are low in those, and so it's tough to cross over with those and be sure. We do know that some inflammatory conditions, like autoimmune diseases, as I commented earlier, there's some data emerging out of, one paper was out of Taiwan for the malignancy, and I think the other one was Hong Kong, but I'm not sure. But they did find there was a significant difference. But between patients that were had an autoimmune disease who had an autoimmune flare versus a new infection. But to be fair, it's oftentimes the PCT is still mildly elevated in the patients that have an autoimmune flare, where it's just significantly elevated when they actually have quite elevated when they have an infection. Does that answer your question, Dave?
Yep, definitely. And the second half of my question is that in the emergency room, we do a lot of discussing around using lactate for severe sepsis septic shock, and using the lactate as, number one, a marker of severity of illness, and two, to watch your lactate clearance over time, which suggests that your therapies are providing resuscitation, and this person's at a lower risk of death with the current therapies you have, and those patients that don't clear their lactates probably need a higher level of care, more invasive monitoring, or a different form of resuscitation, such as using inotropes, something similar to looking at your central venous oxygen saturation. I've seen a couple of papers recently published that look at using procalcitonin as a prognosis marker or severity of illness marker for septic shock and severe sepsis. Just wondering if you have any thoughts on, though I know this isn't your specific area to look at, do you think there's something there that if someone has a really high procalcitonin, that maybe they should be monitored in an ICU setting, or that they're at a higher risk of death and therefore should have more aggressive resuscitation and monitoring?
Yeah, there's a few things. There was a wondering study that just recently came out that looked at actually procalcitonin as a means to, when used in conjunction with outreach teams. So used as an outreach mechanism, and elevated procalcitonin did predict need for ICU admission on an outreach team. So that's one. And two, so I just pulled up this slide from the Greek group. It certainly is associated with mortality. But I guess my other question my concern is I'm not sure that a PCT value would add a whole lot more than something like lactate, or just generally looking at the patient overall. Lactate PCT is $50 a pop. Might be a bit lower going forward at any specific institution if you negotiate well, but in somebody who comes in distributive shock with a high lactate that may be getting better, that makes sense in terms of managing it. And lactate gives us also a fair amount of information from that. So I still am not. I don't know how much it adds that we don't already have at our disposal, and if we're in a realm now of limited amount of resources, and I just don't think it adds a whole lot to the other information that we have otherwise.
Yeah, those are my thoughts as well. I agree. Anyone else have any other questions they'd like to ask Dr. Reynolds?
Stunned everyone.
Yeah, I don't see any hands. You can put your hands up there if you have a question then. Okay, well, I think that might be it, Steve. I don't see any more questions out there. Well, thank you so much for coming today. We really appreciate you giving that talk, and it was a fantastic talk as always. Shari's just going to say a couple words here about how to join the BC Sepsis Network and our Cube Exchange program with the slides that are currently out for people who are attending who are not currently part of the BC Sepsis Network.
Thanks, Dave. So as Dave was saying, we have a lot of great presentations coming up about sepsis and a lot of support calls. We are part of the BC Sepsis Network, and this was established in June 2012 to support clinicians who are working on sepsis improvement. We work to improve the consistency of care, to spread innovation and improvement ideas, to collaborate on change, and to really help teams implement the BC Sepsis Guidelines, which are all listed on our website. The vision of the BC Sepsis Network is to decrease mortality and morbidity from sepsis and to ensure the best possible sepsis care throughout the province. So to join the network, if you're interested, there's absolutely no commitment from yourself. We are just here to support you. Part of our support is offering these free virtual learning sessions. You can join the BC Sepsis Network on our website. Just go to www.bcsepsis.ca. And you'll see on the left side of the menu there that there's a tab to click on the BC Sepsis Network and learn more about what we do and how we can support your improvement efforts. So one more thing I wanted to point out before you sign off. We also have an online community for the BC Sepsis Network, and this is a place where you can go and share resources and discuss with colleagues throughout British Columbia on things that you're working on for sepsis and sepsis improvements. So if you're interested in joining that, the web address is on your screen, www.qexchange.ca. Feel free to join our online sepsis community there, and that's where you can find the recording from today's session if you have any colleagues who missed it. Thank you so much, everyone, for joining us. It's been a great session. Thanks, Dr. Reynolds, Dr. Sweet, for helping out, and we'll sign off now. Thanks again.
Thanks, everybody. Thanks.